kind of the respiratory aspects and haematology of LambMed. Obviously, both of these topics are quite large, so I've tried to kind of condense it into some of the high yield stuff for your formative this week and stuff that you can take forward for the final exam as well. So, shall we get cracking? So, as I mentioned, respiratory diseases is quite a big part, and the syllabus seems to kind of separate it in slightly confusing ways but to some extent, I think the most high yield parts will be things on lung tumors, mycobacterial infection, so TB related stuff, chronic lung disease. We'll do a tiny bit on vascular and infective stuff, and then we'll have a summary slide on microbiology and infection. As much as they love giving you multiple lectures on a lot of the infection aspects of stuff, there are some bits which continually come up in exams. So hopefully we can summarize it into the weird and wonderful, but also the bits that are high hitting. So we'll get started with lung cancer. So the main thing that you need to look for in the question stem, if it's lung cancer, is risk factors. And by far the biggest risk factor for any lung cancer will be smoking, but there are certain ones where it's more so the case. So things like adenocarcinoma, but other risk factors that you should probably look for are things like occupational exposure, so things like asbestos. So if they mention in the question stem, this was the patient is a 60-year-old retired construction worker, start thinking maybe there's some sort of asbestos related things going on. They might have mesothelioma, things like pulmonary fibrosis, so there might be a scar cancer, and radiation exposure. So a classic question will be, this patient is a 43-year-old lady who's had previous breast cancer. She was treated with radiotherapy. It was all fine. She's all fine now, and now she's presented back to her GP with a new cough that's just not going. And you might need to think, okay, the radiation exposure is driving a potential cancer. So in terms of how they present, they'll have systemic symptoms. So these are the B symptoms that you would have covered in MedEd with your 6th year tutors. And I like to use the FLAWS acronym for thinking about kind of these B symptoms. So these would be fever, lethargy, appetite loss, weight loss, and night sweat. So S being sweat, but realistically it's night sweat. And then specific symptoms for lung cancer will be a new cough, but it's typically associated with hemoptysis. So there'll be streaks of kind of blood that will be appearing. And this won't go away because there are some occasions where you'll have an infection where patients will say, oh, I'm coughing up blood, but this will be ongoing for multiple weeks, not just a short duration of time. And then there'll be shortness of breath. And when you auscultate and listen to their lungs, there'll be a new wheeze and it won't be typical. Sorry, I'm just going to have to quickly let in a parcel, so I'll quickly run off. Sorry about that. Where was I? So when a patient presents with lung cancer, it's hemoptysis, so new cough with streaks of blood in it. They may present with kind of metastases. So a common one might actually be brain symptoms or like neurological things. So they might have a new change in vision. They might have a new headache that's just not going. And that's kind of the pressure and the rise in intracranial pressure that might be occurring. And they might have, in women, it's often kind of breast metastases that also occur. They may present with a paraneoplastic syndrome. So we'll be covering this kind of later on, but they'll have endocrine changes where there's a rise in kind of parathyroid hormone or ACTH. So they might present with something like Cushing's, but in reality, it's actually a lung cancer that's driving it. And you'll need to think about hematological things. Now, the lung is near loads of different structures. So they might actually present with things which aren't necessarily respiratory, but actually because there's local invasion. So a key symptom that will come up in the exam will be things like hoarseness of voice, and that's because there's compression to the la recurrent laryngeal nerve, which essentially its course is like down and then loops back up around kind of the esophagus, the lungs, and all of these structures. They'll also have dyspnea because there's obstruction of the phrenic nerve. They might have difficulty swallowing because there's invasion into the esophagus, and they might have Horner syndrome type symptoms. So this is usually quite atypical, but it's this mitosis potosis, and that's usually because of a pancreas tumor. And these are atypical tumors that affect the brachial plexus, and they may get some SVC obstruction, but that's quite small print. So the main subtypes of lung cancer. So you can break it down into non-small cell lung cancer, which is the vast majority of cancers, or small cell lung cancers. Within small cell lung cancer, the big hitter will always be adenocarcinoma. If you're stuck in the exam and you need a best guess, and the question stem says it's a patient that's a smoker, what is the most likely lesion on biopsy? It will be adenocarcinoma, followed by kind of the other two being squamous cell carcinoma and large cell carcinoma. Small cell lung cancers are quite rare. So unless the question stem is leading you to a very obvious finding, don't choose it. And now we're going to go through each of these. So adenocarcinoma, as I said, it's the most common type of lung cancer. And if the question is mentioning that the sample that they've biopsied has glandular differentiation and mucin production. So adenocarcinoma, so adenoma and all of these things. So adenomas are glandular tissues, and they might mention that there's a mucin stain that's identified this for pneumocyte markers. It tends to be more so that they'll mention glandular differentiation and mucin production. And these are often driven by oncotic mutations. So these are things like EGFR, KRAS, and ALK. And ALK is quite specific to adenocarcinomas. The only reason I mention this is that the treatment often tends to be targeted to these specific mutations. And although this is slightly off lab med, they may have one marker that's thrown in. KRAS is a mutation often that is seen in smokers. The way I remembered it is that KRAS ends in S and S is for smokers. If that doesn't really help, just ignore it. So squamous cell and large cell cancers. So squamous cells are the same, it's the same type of tissue that's normally found on the skin. So if you think about it, if you're getting squamous cell tumors in your lung, they'll have things like keratinization and intracellular bridge formation, or kind of squamous cell marker expression. These will be the key phrases in the question that will drive you to think, okay, instead of adenocarcinoma, it might be a squamous cell cancer. It's strongly associated with cigarette smoking, and the kind of pathophysiology is that it drives like metaplasia and then dysplasia to the carcinoma. Occasionally, it could be a paraneoplastic syndrome, and if they have hypercalcemia, so they've kind of got the bone stones, groans, thing going on alongside cancer symptoms, it might be a PTH secreting paraneoplastic syndrome. Large cell carcinomas are undifferentiated. They're a non-small cell carcinoma, as I mentioned earlier, and there's no real kind of sign of differentiation. So if they say there's loads of undifferentiated cells, that's what will probably lead you to large cell carcinomas. Small cell lung cancer, the key phrase that you need to look out for is small blue cell morphology, and that's a neuroendocrine marker. These are pretty nasty lung cancers, but they're quite rare and they're very aggressive. The reason why they're quite nasty is that they're just not suitable for surgery and they need chemotherapy, which obviously means that they're not going to do as well with all the side effects and things. They will probably if they provide a picture, it will look very densely nucleated, so it will be quite purple from the H&E stain, and it essentially looks like there's loads of nuclei squished together. And the main thing that you'll see is that there's lymphovascular invasion that will be mentioned in the question. They will often secrete things like ACTH and SIADH if they're paraneoplastic syndromes, and they're just quite aggressive. So mesothelioma is the main thing that you need to think about. If they say something that indicates that there's a tumor growing on top of the lungs and they're an old ex-builder, think asbestos exposure was probably occurred. They will present very similarly with like shortness of breath, but they'll have kind of this dull unilateral chest pain alongside the weight loss. It's managed with chemo and kind of palliatively. It doesn't have a great prognosis. And as I mentioned earlier, there are paraneoplastic syndromes. So SIADH, think small cell lung cancer, and they'll have hyponatremia. So they might give you a set of bloods, and then there'll be an isolated hyponatremia alongside the kind of presentation. Um, there might be ectopic ACTH. So we went through this last week. So this is one of the Cushing's findings, and it's due to a small cell lung cancer. This is caught a little bit earlier compared to others because they'll have the Cushingoid appearance and symptoms, and then squamous cell carcinoma, I think PTH. Um, okay, so I've got some questions up. If everyone wants to kind of scan the QR code, I will then get the questions up as well. So if I switch over now, have people managed to get onto the Vivox yet? Great, thank you. Okay, I will stop the poll. Sorry, it's just being slow. Okay, have people got the questions up now? Sorry, it's just lagging out. Great, thank you. Okay, and did I cut off? Where was I? Okay, I'm going to start again. So for this question, it's a 68-year-old smoker with a 3-month history of weight loss and persistent cough. The productive sputum is also stained with blood. You're already going to start thinking at this point that it's adenocarcinoma because that's the most common type, which is a non-small cell lung cancer. The bit that often caught me out was just the terminology of non-small cell lung cancer. It wouldn't be unsensible to go for sarcoid because of the whole enlarged hilar lymph nodes, but the previous bits of the history should hopefully start pointing you more towards cancer than sarcoid. But sarcoid can look quite similar to cancer. Is everyone happy with that now? Cool. Okay, so we'll go back to the presentation. So, moving on to TB. So it's a chronic bacterial infection that often looks quite similar to cancer and it's quite nasty. It's caught often in South Asian countries. So off when I was on the infectious diseases ward, I saw a couple patients who had kind of gone on holiday to Sri Lanka, gone on holiday to India, and then come back to the UK with new TB. So if there's this kind of history of travel, you can start thinking about in the question, okay, this might be TB. If it also looks quite similar to cancer, the thing that might drive you more towards it being TB is that the lesions often are in the apex of the lung, and the age range is obviously is variable. So they'll present with a cough, night sweats, fever, late weight loss, and hemoptysis. So very much like cancer. And they'll be treated with this combination therapy of rifampicin, isoniazid, ethambutol, and pyranizumab. They sometimes like to ask in the lab med paper kind of side effects of these drugs. There's no kind of great way to learn it besides just looking it up and memorizing it the day before the exam. Um, Latent TB can be tested using the IGRA or interferon gamma test, and that tends to be better than the tuberculin skin test. So essentially, what this is it's also known as the Mantoux test, and they'll put a little bit of antigen into the skin, and it causes a delayed type 4 hypersensitivity reaction. The only issue is that if you've had the BCG vaccine, this is positive anyway, so the IGRA is preferred. The gold standard and the best way to test for TB is actually the Zeal-Nielsen stain for acid-fast bacilli. So that's what will tell you it's TB in the question. And they love asking about this in lab med. Okay, so chronic lung disease. So we're moving on from kind of cancer and TB and stuff. So there are two types of chronic lung diseases. There's obstructive and restrictive lung diseases. And the way I remember it is that obstructive lung diseases can be learned as ABC, so AABCC, so asthma, alpha-1 antitrypsin deficiency, bronchiectasis, COPD, and cystic fibrosis. And then the rest of them are restrictive. So, in terms of what obstructive versus restrictive lung diseases are, I found quite confusing in fourth year, particularly at the point you guys are at. So I'll try and hopefully make it make a little bit more sense. So when you do spirometry, there are two measurements that are that are obtained. So there's the FEV1, which is the forced expiratory volume, and that's in 1 second. So when they kind of expire, how much volume comes out in 1 second. And then the FVC is how much do they manage to get out in the full duration of expiration. And the normal ratio in, say, me or you would be about 0.7. And in restrictive diseases, this is broadly the same because although the FEV1 drops and the FVC also drops because they've got kind of crunchy lungs that aren't able to expand or contract anymore. So, but the actual airflow is not obstructed by something being in the way. So it's not the issue isn't in air getting in and out. It's actually just the volume that goes in and out is just less than normal. So the ratio doesn't actually change. It's just the volume does, if that makes sense. Whereas in obstructive diseases, there's phlegm, there's infection, there's loads of other crap essentially in the lungs and the airways. That means that it's harder for the air to get out in 1 second, but eventually they'll get air out. So the FEV1 to FVC ratio actually is lower. So COPD, this is kind of the bread and butter of respiratory and lab med. So it's an airflow limitation and it's an irreversible form of airway obstruction compared to asthma. So in clinic, so when you're on placement and stuff, you'll see that they'll do tests with inhalers and things and see that the airway obstruction and the limitation is not changed once an inhaler is given, it still persists. And a key kind of diagnostic thing is that they've had a productive cough for 3 months over for a year, and this is over the course of 2 years. So for 2 consistent years, 3 months of each year have been kind of contained with a productive cough, and the underlying pathology is that there's damage to the cilia, which results in kind of mucus hypersecretion and wheezing. And COPD patients commonly get infections just because they're not clearing their airways in the normal way. Emphysema, on the other hand, is that they'll have this kind of very pink looking face, and that's because they're just constantly catching their breath. And the underlying pathology is that there's damage to the alveoli, and it's a centrolobular emphysema in COPD. And they'll have hyperinflated lungs because there's sort of dead space. If you look at this chest x-ray, it's all black, which kind of represents how it's just hyperinflated. This will differ to alpha-1 antitrypsin deficiency, where there's pan-acinar emphysema, and this is a big kind of differentiating part of lab med that they love asking about. So bronchiectasis and cystic fibrosis are the other parts of our obstructive lung diseases. So bronchiectasis is irreversible and abnormal airway dilation, and it's because there's impaired flow of mucus. The causes of bronchiectasis are variable, and if they tend to get infections, they'll have this very like foul smelling sputum, and that's because they tend to get Pseudomonas infections. In cystic fibrosis, there's a mutation of a chloride channel, so the CFTR gene, which causes mucus to be thicker than normal, and that means it just isn't cleared as well. So they'll tend to get symptoms in most mucus secreting places, so the lungs, but also within the gut, and at times in the pancreas, and in men in the vas deferens, so they'll have male infertility. The way cystic fibrosis is tested for is actually done, it's now done at birth. So they'll do the sweat test on babies, and that's to test for this chloride channel defect. Otherwise, there's genetic testing, and there'll often be a family history because it's a genetic disorder, but it's autosomal recessive. So there'll be less penetrance within the family. Alpha-1 antitrypsin deficiency. So this is because there is a deficit in alpha-1 antitrypsin, which is a protease that breaks things down. And in alpha-1 antitrypsin deficiency, you'll get this loss of elastic fibers, which causes this pan-acinar emphysema compared to the COPD emphysema, which is centrolobular. And you'll get, alongside respiratory symptoms, they'll often have kind of liver defects. So they'll start getting cirrhosis despite not drinking lots of alcohol. The way I think of alpha-1 antitrypsin deficiency in terms of presentation, it's basically like COPD, but there's not a strong history of smoking. And if there's no intervention, there might be signs of kind of neonatal jaundice, but that's quite rare and quite small. By the way, this is a autosomal dominant condition, so there'll be a strong family history as well. So sarcoidosis, this is a granulomatous disease, and it looks quite similar to TB, but the key phrase that should hopefully trigger thinking about sarcoid is that there's bilateral lymphadenopathy. So around the sides of the lungs, around the hilum, there's swollen lymph nodes. There'll also be fibrosis, and it can affect a variety of organs across the body. And then they might present with Lofgren syndrome, which is they'll have an increased temperature, they'll just feel quite lousy and crap. They'll have these swollen lymph nodes. They'll have erythema nodosum, which is these patchy red bumps that often present kind of on the shins and legs, and they'll have polyarthralgia. Something that might point more towards sarcoid compared to TB is that they'll have hypercalcemia sometimes on the bloods, and they'll have an increased serum ACE, but that's not routinely tested. And in terms of eye symptoms, they'll have uveitis. So for pulmonary fibrosis, this is now we're going into the restrictive lung diseases. The question stem will often say on samples or even on CT scans, it looks a bit like honeycomb. And this is because you've lost the normal architecture of the lungs because there's fibrosis and collagen deposition. This can be idiopathic, but so while it kind of occurs throughout life, patients will only really present later on with this progressive breathlessness. And a key thing will be these late inspiratory crepidations in the basal regions. And the question will again mention this whole thing about a honeycomb lung. So, hypersensitivity, pneumonitis, and pneumoconitis. I didn't really remember this until kind of now, but they sometimes like asking this as like a one marker in lab med. It's a breathless cough and it's all to do with kind of allergen exposures. So they might be exposed to things like moldy hay, a bird protein, mold barley, or sometimes it's house dust related. Essentially, the question will be quite leading in this sense because this is quite rare, but they'll say something about it's a farmer that's been working in like a damp region or something. And then pneumoconitis occurs in kind of more, it's more of an occupational exposure thing. And again, it's chronic inflammation that's not an allergy picture and it causes fibrosis. Um, and it's more differentiated by the history of presenting complaint. So there'll be this whole occupational exposure compared to in idiopathic pulmonary fibrosis, where there won't necessarily be anything that points you towards exposure to these kind of organic materials. So pulmonary vascular disease, so DVTs, um, are the big thing when it comes to pulmonary vascular disease. So a DVT is deep vein thrombosis. So this is a clot that occurs typically in the legs and in the veins. And when that gets thrown off, it reaches the lungs and can cause a lot of problems. So this can often occur because patients have been kind of static. They've either had surgery or had infection. And sometimes it might be pregnancy. So even though you might want to say something like an amniotic fluid embolus is the cause of all of this patient's symptoms when they're pregnant, realistically, it's actually a PE that's causing this. So a DVT will present with kind of acute swelling and pain in the calf or more rarely the whole leg, and you might see superficial vein distension, and they'll have this hot red swollen leg with pitting edema. In terms of how they present, they'll be breathless, they'll have a rapid heart, they might be tachycardic at the same time, and they'll have this pleuritic, quite sharp chest pain. Um, So yeah. Now moving on to respiratory infections. So in terms of upper respiratory infections, the main thing is being able to differentiate between viral versus bacterial infection because you don't want to be giving antibiotics when it's not needed. Most commonly, it will be a viral infection that's driving it. If the stem says something along the lines of the patient also has a runny nose, think rhinovirus. Um, Glandular fever, think about it if it's talking about kind of a young person with lymphadenopathy in the preauricular region, which is kind of this area around the neck, also seen in this picture here. Um, Now, the Centaur criteria helps differentiate tonsillitis where it's not viral and in fact bacterial. So they'll have a fever, they'll have these quite large tonsils which have white spots on them. That's the key differentiator for it being um, bacterial. Okay, so RSV, the thing to remember is if it's a child with bronchiolitis, it's always RSV for the purpose of lab med. You don't really need to remember much else. They might mention something along the lines of the kid was born in September, March time, and they might have congenital heart disease as well. But those things might not be mentioned, but if it's kind of bronchiolitis, it's RSV. The CURB-65 score is used to determine the severity of community-acquired pneumonia, not hospital-acquired pneumonia. So say someone's gone into their GP feeling really unwell, and then on auscultation there's crackles on their chest, and they've just not been able to kick this infection for about 2 weeks. It's a community-acquired pneumonia. The difference with hospital-acquired pneumonia is that they've been sat in hospital, they've been either treated for something else, and they've been in hospital for about 48 hours and now started presenting with pneumonia symptoms. The CURB-65 criteria, they do assess this a lot in lab med, so just learn it. It's confusion, urea, respirate, BP, and 65 years or over. And the most likely organisms for a community-acquired pneumonia are H. influenzae or strep pneumo. Now, in terms of the weird and wonderful, I'm really sorry, there's not much logic in terms of how to remember this. It's just kind of remembering that if it's kind of this Chlamydiophila pistillari, it's parrots, Coxiella, is associated with the kind of lamb. So again, there'll be something about a farm, or for the one previously, they'll have like a pet parrot. Franciella tularensis is kind of rabbit associated, and then leptospiral hantavirus is caught through kind of exposure to rodent organic materials. So occasionally you'll see in the JR there'll be a rower that comes in feeling really horribly unwell, and they don't really know what's caused it, and then they'll realize that the rower's boat has capsized and they've drank some water from the ISIS and essentially drank some rat urine, and they've got leptospirosis. So in terms of the other stuff that's quite hard hitting in lab med, and although I'm not given a great way to remember it, if you remember the associations, it should hopefully make microbiome a little bit more manageable. So if the patient's got pneumonia symptoms, but they've been either on a cruise ship, they've been exposed to aircon, so they've been either in a hotel or something, it's Legionella, and the way you test for it is a urinary antigen. If the stem mentions that they've got uncontrolled type 2 diabetes, if they're being really mean, they might give you an HbA1c and show that their diabetes is poorly controlled, or they're an alcoholic, so they might also give you like some LFTs, though I think it would be quite mean of them to do that. It's Klebsiella. If it's an infective exacerbation of COPD, it's H. influenzae, and the same thing is if they've got sarcoid and now have another infection on top of it, it's H. influenzae. So pulmonary edema, the causes of this are either kind of hemodynamic or microvascular. So think about how there's components of the blood. So pulmonary edema is due to kind of fluid from the vessels going out into the alveolar space. So you can either think of it as there's increased hydrostatic pressure, so there's left-sided heart failure. This is mitral stenosis, not multiple sclerosis, sorry. There's volume overload, so they've just been drinking too much water. So this is more common in hospitals where a patient comes in and then they've been given a bag of fluids and it's just gone into the wrong compartments, or there's lymphatic obstruction, which is relatively small print and quite rare. There might be decreased oncotic pressure. So this is the proteins in the blood that keep your fluid in. So if there's a low albumin, or you've got nephrotic syndrome, so you're peeing out protein, or liver disease where you're just not producing enough protein, you're not going to have that drive to keep fluid within the blood vessel, so it will fall out the capillaries and into the alveolar space. Shock lung is a phrase that they like using in lab med, and this is to do with acute respiratory distress syndrome, so ARDS. And the question will mention something along the lines of inflammatory exudate and hyaline membranes. And this is all to do with the fact this was very common in COVID times. So patients caught COVID, they then went into ARDS, and they often were really unwell, admitted to ITU, and it was because they had pulmonary edema they weren't able to kick this off, and they died. And if the autopsy would often show inflammatory exudate and hyaline membranes. So a couple more questions. So if you've got the QR code still loaded, but I'll give you a couple moments to scan it now. Have people managed to join? Okay, I'm going to assume people have, and I'm going to flick onto the other screen. So okay, I can see that for the most part, yes, it is central lobular emphysema. Um, the only time you don't really want to think about idiopathic pulmonary fibrosis, although smoking's kind of a risk factor, you can see that they've kind of led you in the question to think about that they're a lifelong smoker and they've got chronically low oxygen. So you're now thinking, okay, they probably have COPD. Common things are common in lab med. Before you start thinking about pulmonary fibrosis and other things, think, okay, by exclusion, have I ruled out COPD as a diagnosis at this point? And there's not enough information to rule it out. And quite often COPD patients will kind of progress into type 1 respiratory failure. So the answer would probably be central lobular emphysema. A chronic pleural effusion, this is a distraction. So often if COPD patients get kind of pleural effusions and things like that, they'll be quite rapidly unwell with a fever and there'll be signs of infection alongside it. So there'll be these exudative pleural effusions, not transudative. But this is something we can cover later on across the year. I hope that makes sense. Cool. Moving on. So hematology. Hematology is a massive topic. I've tried to cover as much as I can and things that I think are high yield, but there are some bits that aren't covered in as much detail. And if you're confused or anything, you're welcome to kind of email over the next couple of days. But we'll do the topics that are high yield. So we'll start with just a few definitions. So hematopoiesis. So think of it as hemato means of the blood, poiesis means generation. So hematopoiesis is generation of blood cell components. This starts in the fetal liver at 5 to 8 weeks gestation, and as they develop, this will go more and more to the bone marrow. Erythroid is just a term meaning red blood cells that carry oxygen. Reticulocytes, or retics, as Debbie Hay loves to call them, they're immature erythrocytes. So they're nucleated and they're polychromatic. So if you look at this picture on the side here, it's a blue stained blood film. This is what a normal red blood cell would look like. And then you've got these densely nucleated, random looking cells that are a bit less frequent on the blood film. That's what a reticulocyte is. Lymphocytes are just B and T cells, so they're the adaptive immune response, and myeloid cells are the innate immune response cells. So think your macrophages, your granulocytes, so your neutrophils, and megakaryocytes, so all of your like clotting platelet factors and stuff. Here is a more visual version for you to go through in your own time. So anemia, this will almost definitely come up in the formative and will probably come up in the actual exam as well. So although you probably had a lot of teaching on it, it's still good to kind of go through this again. So anemia is essentially it's not enough red blood cells or hemoglobin in the blood. The normal ranges vary between men and women, and the key kind of triad of symptoms is this pallor, so paleness, shortness of breath, and weakness. And anemia is classified by its by the mean cell volume on the full blood count. So microcytic, so less than kind of 80, normocytic, and then macrocytic. The cause of anemia you can think about within the different stages of red blood cell production. So if there's poor EPO production, so in things like chronic kidney disease, where although the HIF pathway's activated within the kidney, because the kidney's damaged, it doesn't produce EPO, you could get anemia. So this is kind of the more anemia of chronic disease or chronic kidney disease. If there's lack of components for red cell synthesis, so these are your iron, your B12, your folate, all required for blood production. If you've got defective red blood cells, so this is your thalassemias, your sickle cells, and then your slightly more small print and weird and wonderful G6PD deficiency and things, or if you've lost red blood cells. So this is where you need to start thinking high reticulocytes. Is there active bleeding? Is there hemolysis? So, microcytic anemias, this is where, as I mentioned earlier, the MCV is less than 80 and the red blood cells are smaller than expected, and that's because there's reduced hemoglobin. So, the most common cause of a microcytic anemia, and the one that you should be thinking about before any other cause, is iron deficiency. And the causes can be due to kind of excessive blood loss. So, if the question is mentioning a young woman who has heavy and painful periods, think iron deficiency. And if it's an old man, you need to start thinking, is it a GI bleed? If it's kind of anemia symptoms and kind of change in bowel habits, so they might have melena or dark stools, you need to start thinking, is it a GI bleed? And the test that you would do for this is a FIT test. It's a antibody test which essentially tests for occult blood, so traces amount of fresh blood within the stools. But the main thing is that the FIT test won't detect anything beyond a low GI bleed. So if it's an upper GI bleed and the blood is digested, a FIT test won't be useful. If the question stem mentions vegan or vegetarian diets and there's a microcytic anemia, it's iron deficiency. And it can also be caused by celiac disease, um, where there's issues within the duodenum which prevent iron uptake. And you might also get a mixed picture. So sometimes patients will present with a macrocytic anemia because there's folate impaired absorption. CKD can cause a slightly mixed picture, but often can cause iron deficiency due to kind of hepcidin action. So it blocks the iron uptake transporter within the intestine, or less commonly put in exam questions is that if there's increased iron requirements. So if it's a child with anemia, or if a woman's pregnant, just because there's increased demand of iron and blood, there might be a macrocytic anemia. The key investigation that will tell you it's iron deficiency is not the serum iron being low, but the ferritin. So if the question asks what should you do next following this microcytic anemia, it's ferritin. The blood film, they might have it and they might mention these words. So target cells or picokelocytosis or picokelocytes. This is what target cells look like. They literally look like a shooting range target. And the way this is treated is iron replacement. So thalassemia is your kind of next hitter for microcytic anemias. It's a globin disorder, and it's due to a mutation which causes either poor production of your alpha chains or your beta chains. So in alpha thalassemia, you get poor production of this alpha chain, which means that your body compensates by overproducing the beta chains, and it's poor hemoglobin that doesn't function as well. And in beta thalassemia, it's the opposite. The way this is diagnosed is high performance liquid chromatography, and they may give you the results, but I think it's less likely to occur. And then these are the different kind of presentations you can get. So beta thalassemia can kind of present as a spectrum. So where there's only one mutation in the beta globin gene, they might be asymptomatic with a little bit of anemia, but for the most part, they live a pretty normal life. If they've got beta thalassemia intermediate, they've got mutations in both the beta genes, but they're not that problematic. So there's a slight increase in the alpha, but it's not transfusion dependent. They can still survive. Whereas beta thalassemia major, they've just got dysfunctional beta globin genes, and it's completely transfusion dependent. The final, slightly more small print cause of microcytic anemia is this sideroblastic anemia. Don't click this unless there's evidence of it. So if the question says there's ring sideroblast, or they show a picture that looks like this, where there's these dots of blue around this dense pink nucleated region, essentially due to the fact that it's due to a mutation in the iron incorporation of hemoglobin. So because you can't get the iron into the hemoglobin, it's just they're dysfunctional cells. And effectively it's a relative iron deficiency. So it's not that they're actually deficient in iron. They've just got, so they will have a raised ferritin for this reason, as they won't necessarily have a raised ferritin. But the question will make this quite obvious. And the causes can vary, but it can be either congenital, so due to a mutation, or acquired from like alcohol abuse or certain medications. And you treat this by either stopping the alcohol or the drugs and giving them paroxetine. Normocytic anemias, the thing to kind of think about in normocytic anemias is if there's evidence of hemolysis or hemorrhage. So this is where, if in the question they're giving you the reticulocyte count, start thinking, is there evidence of hemorrhage or hemolysis? Obviously, the question stem for hemorrhage might be really obvious and say there's acute trauma, they've been in a car accident or something. But they might give you a slightly more niche presentation of something like an esophageal varice, where it's a patient that drinks excessively and then has been vomiting. And now they've got a reduced hemoglobin. It's because they've got a normocytic anemia secondary to a variceal tear. The way this is treated is stopping the bleed and transfusing it. So for a variceal bleed, that would be kind of surgical repair. So in hemolysis, like I mentioned, you will see a raised reticulocyte count, and hemolysis is increased red blood cell destruction, and this can be due to a variety of causes. The genetic ones I've listed here, and hereditary spherocytosis is one that you need to know for the exam, and it's due to a cytoskeletal protein defect, which causes the red blood cell to not have that normal biconcave shape, and effectively it breaks down quicker. So you'll see these spherocytes on the blood film, and the cells will be breaking down, so there'll be evidence of literal shattered bits of hemolysis. And this is tested via the EMA binding test. There's no easy way to remember this besides just kind of remembering it. And then for G6PD deficiency, it will be this history of a child with jaundice, and they're often of kind of African or Mediterranean descent. And if they provide the blood film, they'll mention something like Heinz bodies. The way I remembered that was quite silly. It's the fact that I thought, okay, if this is common in children, kids eat Heinz beans a lot. If that's not very helpful, just ignore that. The way you investigate for hemolysis, so once you've seen this increased reticulocyte count, is that you do the Coombs test, and that's to test for autoimmune hemolytic anemias. So the Coombs test works by the fact that in the patient's blood, they've got direct antibodies to the red blood cells. You then add this thing called Coombs reagent, which then will bind to the kind of non-antibody, the non-antigen binding section of the antibody, and agglutinate. And then that's what's positive. The difference will be is that you have these two types of hemolytic anemia. So you can either have warm antibody hemolytic anemia, and that's driven by IgGs, and it's quite often associated with chronic lymphocytic leukemia. They will sometimes say that the patient's either got a past medical history of chronic lymphocytic anemia or some leukemia, sorry, or they'll often give you a question where the patient's presenting with a hemolytic anemia, and then it'll be like, what's the most likely diagnosis? And you might need to remember it's CLL is associated with this. The other thing that hemolytic anemias, particularly the IgG variant, are associated with is lupus. So the last thing to remember is that there's microangiopathic hemolytic anemias, and this is a type of intravascular hemolysis that happens effectively in the context of infection or kind of platelet dysfunction. So platelet dysfunction tends to happen either due to infection, so in cases of DIC, or where there's sepsis, or HUS, which is hemolytic uremic syndrome, where you've got this E. coli 0157 infection, and the question stem will tell you the patient's had diarrhea if it's HUS. The genetic cause will be TTP, and that's an Adams 13 mutation. Um, they don't present nicely. They look quite unwell. They'll have thrombosis, so they'll have purpura and bleeding. They'll have an AKI. They'll have jaundice and a raised lactate. And the thing that might point you more towards MAHA is this schistocyte appearance on the blood film and fibrin strands. So it's literally because there's fibrous material within the blood that's causing these cells to literally be shedded apart. This is a diagram summary that I found quite useful, and I've just popped into the slides and you can review it in your own time. It has probably a little bit more than what you need to know, but it's useful. So, anemia of chronic disease, it's a diagnosis of exclusion. Uh, Chronic diseases, there's multiple, you've covered them across lab med. The treatment for this is try to get the chronic disease under control, and the anemia in theory will correct itself. If there's often in clinical practice, there'll be it might be a mixed picture with iron deficiency, so they'll also give them iron supplementation. The other thing to remember for hematology is that sometimes it will be these myelodysplastic syndromes. So think about your AMLs or your CMLs. They'll have bone marrow failure and pancytopenia. So it'll be anemia, but it will be also in the context of them having recurrent infections and poor clotting as well. So start thinking, is it bone marrow failure rather than just kind of a normal, an otherwise anemia, an isolated anemia, I mean. So macrocytic anemia. This there are two causes. So this is either B12 or folate deficiency, and you will see hypersegmented neutrophils on the blood film for a B12 deficiency, and there might be a history of celiac, or there'll be this picture of celiac disease. So they might mention things like the TTG testing or IBD history, and occasionally it can be drug induced. The treatment for this is IM or B12 replacement. In quite severe cases of B12 deficiency, they might present with the subacute degeneration of the spinal cord. So folate deficiency, the causes again are like iron deficiency, where it's either low intake, a gastrointestinal defect, so kind of conditions that cause poor absorption or just interference with absorption. The other cause to think about is methotrexate. So this is a medication that directly inhibits folate metabolism in the body, and it's used to treat rheumatoid arthritis. So if the question says they've got rheumatoid arthritis and they mention methotrexate, it might be actually this that's driving a folate deficiency. There might be increased demand. So again, pregnancy. You will again see hypersegmented neutrophils on the blood film, and the question will tell you it's folate because there'll be direct reduction in folate. In terms of management, you always replace the B12 before the folate because of this risk of subacute degeneration of the spinal cord. And the causes for a folate deficiency are listed here. So these are just some summary slides for anemia. So the first thing you should do if it's an isolated anemia is check the ferritin, and then you look at the other iron studies. So transferrin is a slightly confusing one. So transferrin is what's is a protein that helps move iron around the body. So the body will produce more transferrin when there's low iron in the hopes that it can catch more iron, but the actual saturation, so how much is bound to iron, is actually lower in iron deficiency. Um, and the ferritin will be low in iron deficiency. And then this is a nice little just summary diagram. And here's another table. So if everyone can hop back onto the VBox, and if just people react that they managed to get onto it. So I'll give a minute or two just to scan the QR code. Or would it be helpful for me to just put the code in the chat? Okay, fine. I'm gonna hop over onto VBox. Okay. Sorry, this is a slightly mean question, but hopefully it's useful. Okay, excellent. Yeah. So the answer is warm autoimmune hemolysis. For those of you who answered cold autoimmune hemolysis, essentially the difference in this question stem was this bit here about IgG testing. So if the question tells you either the Coombs test was positive above 37 degrees, then it's this one, warm autoimmune hemolysis, and it's IgG mediated. So they might flip the question around about either temperatures, or the key is that warm autoimmune hemolysis is IgG mediated, whereas cold autoimmune hemolysis is IgM mediated. I'm sorry, I don't have a kind of fancy way of remembering that. I just had to learn it as well. Okay. Fine. We will go back onto the slides. So I'm going to try and quickly summarize some myeloproliferative and lymphoproliferative neoplasm stuff, but I appreciate that these were about 6 lectures, so I'll try to condense this as much as I can into a couple slides. So a few things that I found quite confusing was just the term. So leukemia is actually cancer of the bone marrow, and you can get both myeloid and lymphoid problems because they originate from the bone marrow. So this is why you get CLL and CML, for example, and they present with systemic symptoms. So think of those B symptoms, whereas lymphomas are cancers of mature lymphocytes. So that's when they've got into the lymph nodes, they've formed their germinal centers and all of that stuff. And lymphomas present as a lump or a mass, and they tend to be a neck lump or mass. The only kind of exception to this is myeloma, which is a cancer of terminally differentiated lymphocytes, so plasma cells. So there'll be an overproduction of plasma cells, and they'll be producing loads of this kind of antibody-like protein. Myeloproliferative neoplasms are due to kind of overproduction of blood cells within the bone marrow, and there'll be proliferation of one or more of the cell lineages, so either the red blood cells, the neutrophils, or kind of the clotting cells, so the megakaryocytes. And then lymphoproliferative is excess lymphocytes, and it occurs mostly outside of the bone. So in terms of myeloproliferative neoplasms, the ones that you need to know are polycythemia vera. So this is essentially the opposite of anemia. You have too much red blood cells, and because you've got too much production of your erythrocytes, your blood is more sticky, it's more susceptible to essentially clotting. So they might present with signs of kind of a DVT or something that looks a bit more like an ischemic event. And then on a full blood count, they'll have a raised hemoglobin, a normal MCV, and a raised hematocrit because the concentration of red blood cells has increased within the blood. It's due to a JAK2 mutation, and the way you sort of treat it is literally by bleeding off the excess blood, so venesection. And then essential thrombocythemia um is a is a neoplasm where you've got excess platelets rather than necessarily in PV where it's an isolated rise in hemoglobin. You might also get a raised HB at the same time in ET because a lot 60% of the mutations are JAK2 related. The other mutation to be aware of is CALR. They might present kind of post splenectomy, they might have infection symptoms. And the key thing to remember is that you treat it with aspirin. These two both can, although they're kind of chronic conditions, they can then transform into AML. So they will become an aggressive cancer if not treated. And then myelofibrosis is when your bone marrow gets fibrotic, it gets damaged, it kind of gets all scarred, and you'll get a pancytopenia in this. And the only way to treat this is really a transplant. CML is they love asking more about the cause of it. So CML is due to a translocation, and it causes this formation of this BCR able gene, and they probably rattled about imatinib, which is the targeted treatment for this. In terms of how patients with CML present, it's this long rumbling kind of pain in the region of where your spleen would be. So this lower kind of lower quadrant of your chest abdomen region pain with alongside the B symptoms, and on a blood film you'll see these blasts. So CML can be caused either by the actual original stem cells or the myeloid stem cells themselves, but they won't see blasts, which is different to AML, which is a cancer of the myeloid blasts, and you get pancytopenia, anemia, and infections because you've got a reduction in both your red blood cells, your white blood cells, and your platelets. So that it's pretty nasty. They'll often have fever, they'll have infective symptoms, but also the fever just might be because of the cancer itself. They'll have the anemia symptoms of shortness of breath, palpitations, feeling just generally quite lousy. Sometimes if it's really severe anemia, they might feel dizzy. Thrombocytopenia will present as petechiae, so these like red blotchy marks across the skin. This question stem might mention something along the sides of gingival bleeding or increased nosebleeds. And occasionally they might mention bone pain, but this is more small print for AML. And the way you investigate this is a full blood count, which shows pancytopenia with a peripheral blood smear, which shows an increase in myeloblasts, which can be confirmed with bone marrow biopsy. But I think because it's quite a invasive procedure, they're trying to reduce the number of bone marrow biopsies they're doing within hematology. So high-grade lymphoproliferative disease. The way I remember it is that if it's a young person and they've got a history of having kind of glandular fever or EBV or tonsillitis, it's Hodgkin's lymphoma, and they'll have this classic Reed-Sternberg cell on inflammation. And it's kind of a cancer of the young, tends to be kind of the teenage years, so our age and kind of slightly younger. Burkitt's lymphoma is a cancer that tends to occur in quite young children, and it's a rapidly growing lump that's also associated with EBV, but the biopsy will say this starry sky appearance. whereas a diffuse large cell B cell lymphoma is a cancer of the older and it's associated with HIV. Again, it'll be a rapidly growing lump. Um, and it will be this infiltrative histological picture. Myeloma is the final lymphoproliferative disorder I'm going to cover, and it's a malignancy of plasma cells, so the differentiated B lymphocytes. And the way I remember the symptoms for this is crabby, so CRABBI. So it's hypercalcemia, renal light chain deposition, so it will cause lots of like renal damage, anemia, bleeding, and bones. So there'll be back pain quite often due to a secondary pathological fracture and infection. And the way you investigate it is a full blood count, but often the question will ask, okay, there'll be an elderly person with back pain and some other symptom from this list. Um, what should the GP do next? And one of the options will often be bone marrow aspirate, but what you should be doing beforehand is a protein electrophoresis to pick up the IgGs or the power, essentially the myeloma paraprotein. So these are proteins that look a bit like antibodies that are produced from the plasma cells. And in a urine sample, you'll see this Bence-Jones protein, which is essentially just more paraprotein within the urine. So we'll do a couple more questions now. So I will, if people have managed to scan the code, I will flick back onto VBox. So if people scan on, okie doke. Are people in? I put the code in the chat to join the VBox anyway, so hopefully you can get in. Okay, nice. Yes, it's 922 translocation for CML. Okay, these two, so the 912, it's just make sure you remember it's 922 translocation, not 912. And then this is a completely different mutation for a different thing. Okay, moving on. So this is a summary slide for the B symptoms, so the kind of stuff that you see for lymphomas, and I hope it's useful. So to do with the whole lump, no lump, and should be able to help you kind of rule things out. A longer history should hopefully point you more towards follicular lymphoma. If it is a low grade lymphoproliferative disorder, it's probably lymphoma. I'd go for your best guess. If it's kind of a lump, and then if it's not a lump, think about CML and CLL. So anticoagulants. So you've got prothrombin time. So this is to do with factors 2, 1, 2, 5, 7, and 10. APTT is affected by 1, 2, 5, 7, 10. Sorry, 8, 9, 10, 11, and 12. And then INR is a term, it's essentially a ratio of kind of PT and APTT, but it's used specifically in the context of warfarin monitoring. And then TT is thrombin time. This is a table I made just to help kind of summarize the different types of anticoagulants. So warfarin's the only vitamin K antagonist, and it's the only one that requires monitoring. and you do this via INR. So you on a blood result, if someone's on warfarin, you would expect an increase in prothrombin time because vitamin K affects factors kind of 2, 7, and 10. And then you've got the direct oral thrombin inhibitors, and which is kind of dabigatran. So uh, they will prolong the thrombin time and they don't really change PT, and it's not really routinely monitored. The ones to remember are these direct 10A inhibitors. So apixaban, rivaroxaban, edoxaban. The way I remembered it is that all the ones ending in ban are direct 10A inhibitors, and then dabigatran isn't really used as often clinically. And the thing to remember is that they prolong both prothrombin time and from PTT. So platelet disorders. I'm going to very quickly rattle through this. So you've got ITP, which is an immune-mediated reduction in platelets, and quite often it's seen in women post kind of pregnancy or during pregnancy, or it can be occasionally triggered by having a different malignancy. They'll present with a petechial rash. This can be differentiated to DIC, where the patient's often septic and they've got a prolonged PT and APTT, and that's because you've got your clotting factors getting used up from all these microclots forming. TTP is due to a deficiency in the Adams 13 enzyme, which leaves von Willebrand factor, and you effectively cause loads of procoagulant plugs to form in excess, which then consumes platelets. So it's a relative reduction in platelets because you're overforming platelet plugs. You get the pentad of thrombocytopenia. You've got this Maha picture that we went through earlier, alongside fever, neurological signs, and renal failure. But the latter two will probably be seen in later stages. Hemolytic uremic syndrome is the next step up. And it can be seen as an infective etiology, and it's almost always associated with E. coli 0157. And you'll see evidence of an AKI. They'll often give you the blood results. And then heparin-induced thrombocytopenia, I wouldn't really worry about for the exam. So I think I've got one more question left to do on the VVOX. So if people hop back on, I can pop up the QR code to scan for that again. Okay. People in? Okay, I'm gonna assume people are in. Great, thanks. I'm gonna open the poll. Great. So, final question. So it's a 68-year-old man, back pain for 2 months. So keywords back pain. What are we thinking about now? So it's an older man. So we're thinking, okay, it's not going to be kind of Hodgkin's lymphoma or anything already. They've not got a fever. They've got a reduced low blood pressure and a high pulse. There's no JVP and no neuro symptoms. They're anemic. Their white cell count is fine. They've got some reduction in platelets. Okay. There's some